Good afternoon, everyone. Welcome to the fourth and last webinar out of our four-part webinar series on dementia across the spectrum hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Karen Chan, and I'm your moderator today. I am an associate professor with the Department of Family Medicine at the University of Alberta. The Office of Lifelong Learning and PLP are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I'd like to give the land acknowledgement at this time. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nihio, Cree, Niitsitapi, Blackfoot, Métis, Nakota, Stoney, Dene, Haudenosaunee, Iroquois, and Anishinaabe, Ojibwe, Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and homelands of the Métis. The University of Alberta respects the sovereignty, lands, histories, language, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I have a few housekeeping items to go over. I'd like to start with asking you to please use the chat feature if you have a question about technical difficulties or the L3 PLP programs or services. If you have a question for the speaker, please do use the Q&A feature for the webinar. You can review what has already been asked in the Q&A and upvote those questions that you would like answered by giving a thumbs up. We cannot guarantee the panelists will be able to respond to all your questions, but we'll try our best. A recording of the webinar will be sent via email to all those that are registered. And I believe it'll be available as well on the PLP website or Office of Lifelong Learning website afterwards. Participants can claim CME credits and complete a personal development activity using my L3 Plan tool. For more information, visit the QR code that you see here. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credits. MainPro participants may also earn additional certified credits by completing a linking learning exercise. Today, we're very pleased to welcome Dr. Diana Rucker again, who's really been the champ in doing 4 of these talks. And she's going to be talking about the practical approach to capacity assessments. She is a clinical associate professor at the Department of Family Medicine, or Department of Medicine, sorry, here at the U of A. I knew that. She completed her medical degree at the University of Calgary in 2004. She subsequently completed training in internal medicine and a fellowship in general internal medicine at the University of Alberta, followed by a fellowship in geriatric medicine at Harvard. Her academic interests focus on decision-making capacity, particularly its impact on hospitalization and cognitive outcomes among socially vulnerable populations, including individuals experiencing homelessness. Thank you very much for your time and welcome everyone to our webinar today. I'll pass it on to you.
Thank you, everybody. This is my last talk. I saved the best for the last. This is a topic I'm very passionate about, and I'm going to share with you my approach to capacity assessments. I don't have many disclosures. I recently received an honorarium from ESI, and this is where we are today, our final talk webinar in this series. It's called the 444 Practical Framework Approach. And I'll just, generally just do some basic definitions and common terms. We'll talk about emergent versus formal capacity. Then I'll explain what my 444 approach is. And then I'll also review the practical side of filling out forms, because that sometimes can be daunting. So really, this talk, it kind of started out with me just teaching capacity over and over to the medical students. And then after a while, I thought, oh, I should just try to write this up as a paper. And then, of course, references came in and co-authors, and it just was like the whole thing went to a spa treatment. And I actually, if you wanted to, it's been accepted to be in press with the Canadian Journal of General Internal Medicine, which is not an index journal yet. So you might not find it on PubMed, but if you search in the next couple of months, you may get a permanent reference to this. So it's really just so I always stress it's very important to balance, or like capacity is such an important concept because it really balances. It's like this fulcrum that balances autonomy from preventing harm. And we should always take it very, very seriously. When I first started practicing, I kind of thought capacity and competency are kind of almost like interchangeable. One's used in the courts, one's used by the doctors, but it is a little bit different. Clinical capacity is very task specific, and competency, while it is mostly used in the courts, it's more of a global ability. So often, the way you can think of it, the courts may ask a doctor to assess a specific capacity in order for them to determine if the patient or the person on trial has overall competency to stand trial. Now, having said that, how do I define capacity? And I like to keep it very, very simple. And that way we can all remember it's simply decision-making ability. And I just wanted to remind everyone of the terms I'm going to be using. These are the terms in Alberta. So basically we break everything into personal decisions or financial decisions. And a way to explain it to patients, they'll go, oh, yeah, 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 I have a will. And you go, no, no, but this is like a living will. So if you choose an agent and attorney, respectively, now if they miss the boat and they aren't really able to have that ability to pick a decision maker, then the courts will appoint one and it becomes a guardian and a trustee for the money. And furthermore, if it's a private, that means a family or a friend is applying for it. And if it's public, then that means it's like a court appointed guardian or trustee. Oops, where is it's not forwarding. Yes, so I think, sorry, been a repetition of the slide. So having come back to this term competency versus capacity, I love, I work in Connect Care a lot, doing my charting, and I'm always all about the coding. And having given you that like chat about how capacity and competency are very different, when you actually code for it, it's like encounter for competency evaluation. So, it is what it is, but it's not perfect, but that's what they're a little bit behind the times, I guess. And then I have this concept, kind of a resident once told me that it's important to know that there's different kinds of capacity assessments. So sometimes, like, you don't have an agent or a power of attorney, and family may not even be present, and kind of call that emergent capacity assessment. And we'll talk about that just for in one slide. And what I'm going to talk about on this side is really that, like, that formal capacity assessment. It's domain specific and it's kind of a more forever thing, although it can be fought against and reversed in court. There's also this one in between, what we call Form 6. Again, there's no formal PD or power of attorney in place, but you can sometimes do this one-time decision-making thing. Now, it doesn't work for finances, but say if you have someone who the family has access to money, then because money is often really the limiting thing to getting people into, like, say, if they need higher level of care, as long as the money is there and we have access to that, you can do a one-time decision-making process and move them, say, to transition unit or to another facility using just a Form 6. Psychiatry will quite often use this, say if they have to give a certain medication, but it's really important to note it's just a one-time thing. So even like in psychiatry, if they have multiple medications, they'll have to do a Form 6 for every medication. These are this acute emergency situation. So if you don't have anyone, it's really important to try and identify who the alternative decision maker could be. And you can look at prior goals. And then you act in accordance with the patient's best interests. Like, is there a documented DNR? An emergency treatment is only really when specific criteria are met. If a patient lacks capacity, they're not responding, there's no alternative decision maker available, and the patient's preferences are unknown, and that you need immediate action to prevent a loss of life or limb. So I'm going to move on now and talk about the 444 framework. And really, it's three things, and they don't necessarily have to be in any one framework because really your brain is going to use all three of them. But I've kind of divided them into the four core skills of capacity, the four practical rules, and then we'll hit the four types of capacity scenarios. So, what I always say to my learners, and I wag my big finger and I say, you are able and expected to do capacity assessments when you complete your training, which it's just like one of those medical things you graduate with, and you're like, wait, did I ever actually learn about this? Because, like, certainly when I went to medical school, we weren't really taught any of this, right? And so I say, when you go back, you can translate that. This is not a big fan of mnemonics, but this one works so well. You are expected to do capacity assessments. And so these are really the four core skills. You can see the reference below Applebaum and Thomas Griso. He's a forensic psychiatrist, but um, it's been almost like 4 decades that we're coming up on this, but the four core skills are understanding, appreciating, reasoning, and expressing, right? So understanding is just like, can you understand the situation? It's really good if they actually paraphrase it and then they can retain that and give it back to you. And like this includes then appreciating like the risks and the benefits, like say what would happen if you had treatment, if you didn't have it. And also, how does it affect me? Like, what if I didn't have this or did have this? And then you want to see them reason, so generating different outcomes. And you want to see that justification or rationale of what their choice is. And expressing is communicating, but an important fact here is that not only are they clear in what they're saying, but they're consistent. So we know in dementia, like, that short term, that recall memory is so short. Like, literally, if you don't have to wait a day and assess them the next day. If you just change the topic and then come back and say, can you tell me who again you would choose or what you would do? You want to see a consistent choice. And if you see, this is like the Alberta schedule. You can see those terms on the actual sheet that you would be filling in. We'll come back to this, but here you see it: understand, retain, appreciate, communicate. This is a BC form: understand, reason, appreciate. So very similar terms, right? Now we'll move on to the four practical rules that I have kind of come up with. It's kind of funny. It started with like two rules and then it became the three rules. And that was fun because it could be like the three golden rules. And then the fourth one actually came out while I was writing this paper. So the rules are: you have to have a trigger. And then you want to make sure that a functional assessment is done, especially when it comes to like, where is this patient going to live? You want to remember that capacity is really task specific, and you want to also consider past and future risks. So the trigger before capacity assessment is going to be your most important thing. One of my colleagues, Leslie Charles, she works at the Glenrose. She actually did a paper and she found that 4 out of 5 capacity assessments didn't really have a trigger. So often people are just confused and they'll go, oh, I need the capacity assessed. Um, but there are some, I would say, exceptions when you probably do need to do it. Quite often, if you have someone who waffles on their decision, and they need ongoing medical treatment. So, for an example, I had a lady who had sort of advanced multiple myeloma, but she was going to get some palliative treatment. But she kind of waffled. Like one day she wanted it, then she didn't. Her husband really wanted it. So, just to make it easy for the oncologist, we just, enacted her personal directive, and that way she could get the treatment, and it wasn't this big decision for her. Locked dementia units, especially if the person is a wanderer, like a known wanderer, and you're putting them into a locked unit, that enacted PD almost acts like a permanent Form 1 mental health act. So the caregivers, if they do escape, can actually walk that person back to the unit. So we have our first case here, Mr. Sliffer. 86-year-old man living in a seniors independent facility. His niece asks to be the alternate decision maker to be enacted because the facility says um, that they can no longer manage him. And recently, in the dead of winter in January, he walked across to Safeway to get stuff, wearing only slippers and his pajamas. It was during one of those cold snaps, and the temperature was minus 31 degrees. So, what would be the trigger here? Is his niece asking for it the trigger? Is it because he has a potentially life-threatening event? Is it because the facility says they can no longer manage him? Or is it like B and C? Yes, perfect. I would say B and C is the answer. When people, often family will want the capacity, and that's what I was trying to kind of get across, that just because they want it and act it, it doesn't mean that there is an actual trigger because they don't understand what triggers are. Definitely in this situation, that he walked out in a really dangerous, cold situation and could have like ended his life. Like that's a done deal. I had like similar lady, and she would wander. She had like two episodes of wandering, but it was like the summer, and she would kind of knock on her neighbors' doors and then would find herself back. And I just knew she wouldn't qualify. And that was indeed the case when we asked, like they wanted her capacity taken away so they could place her. But I knew she wouldn't qualify because she was too physically good. So in this case, like we have, a really like life-threatening situation, but also the facility is telling you that they can't really manage him anymore, which is a pretty good, and it kind of ties into some of the other things we'll talk about, but it's a really good indicator that you may need to do a person like move on and act the PD. Whoops. So I made kind of a list of triggers and is not a trigger. So in medicine, like if it's for medical therapies, if it's really risky therapy with minimal benefit, but the patient really wants it, then you might want to assess capacity. We talked about the locked unit. If they're going to any institutionalized care, but they really are voicing that they do not want to go and they are functionally able to wander away, then you would probably have to enact the personal directive. There's ongoing medical therapy. We talked about that one. If they have no alternate decision maker and they need a capacity assessment, and we'll get into that. If they have capacity to pick a decision maker, that is really important. If they are physically or cognitively unable to do the banking, you may need to do a capacity assessment just for the money part of things. And if there's been a really significant financial history of abuse and exploitation, so, like, if somebody is going to a higher level of care, but they're agreeing, then you don't have to assess it, even if they have documented, dementia or if they've made like really get this all the time in the hospital, they've made really bad decisions. They're like under the influence of drugs, alcohol, or bad friends. But they don't qualify for a locked unit or higher level of care. I strongly suggest you think about that one because you don't want to take their decision-making ability away on paper and then send them out into the community to live freely. Like you haven't really found a safe place for them. I hope that makes sense, right? Um, and if you sometimes like the money things and the financial abuse can get really confusing, but if you suspect that when you enact the PD that it might make things worse, I would probably hold off on it, unless you have guidance from the Office of the Public Guardian. So the next trigger would be, or the next like practical skill is always determine the function, especially if it's like where to live. So again, Thomas Griso, he kind of revolutionized this, and he said, you have to assess functional abilities relevant to the capacity in question. And that is fundamental. So if you have a judge who's going over it, he's going to want to also know, like, what can this person do or don't do? And another author, Colopy, I have the references below, he said he calls this autonomy of execution. The ability to implement personal choices is crucial in determining if a person retains the capacity to choose where to live. So if you have a patient says, oh yeah, like I can totally go home and do this, but they're not able to show that in a hospital, that's really important, right? Collateral history can often about where they are functionally at their baseline before they got sick is also very important. And assessing if they would qualify for, as I mentioned before, for this institutionalized care. The placement is biased on function more than cognition. So we see this quite often that people like in their dementia, I said before, like, it's this balance between cognition and function. If they're functionally really, really good, they may not qualify for a higher level of care. So you have to be really careful about enacting their capacity and taking their autonomy away, because then you'll be legally responsible. So this is a kind of a perfect example of that. I just had this gentleman in a couple of weeks ago, Mr. Gamble. He's a 79-year-old gentleman. He has heart failure and his cog screen, he's very low, 13 out of 30. He's got no PD, no power of attorney, which makes this all so much more complicated. He previously actually lived in seniors housing that provided meals and cleaning for 7 years, but he gave notice because he figured out that if he goes to a homeless shelter, he gets to live for free, and that would free up a whole ton of money so he can go gambling in the casino, and that's what he wanted to do. When his heart rate decompensates, he usually knows to come to the hospital for treatment. And once his heart failure is stable and he has full activities of daily living, and he was like leaving the hospital for 4 to 8 hours, code yellow, to either visit his girlfriend or go to the casino. So I got kind of like an angry, not an angry, but I should say, but kind of like this message from, the heart function clinic, like why hadn't I enacted his PD? Why did I let someone who clearly lacks insight? Why hadn't I placed him? And this was the situation, right? So what would you do in this case? Would you take his capacity away because he lacks insight? Work with his sister to make a power of attorney slash PD, let him leave, but carefully chart that he's leaving against medical advice, or B and C. And Simon says, what do we have? Yes. So B and C is the right answer here. I mean, you could, in this case, he left so quickly. We were trying to establish the power of attorney. As soon as he got wind of it, he bolted. And so basically all I could do is like write in the chart and said he left AMA. Um, and I wouldn't take his capacity away because you haven't found a place for him to live safely. And he doesn't qualify like for a locked unit. And he was at a good place, like like the seniors, the independent living, which could have home care come in to remind him to take his meds, but he didn't want to live there and he gave that up. So the next kind of practical skill is that capacity is very task specific. We talked about this earlier. We can all operate cars, but very few of us can operate a plane. So that's like a saying someone gave to me years ago, and I haven't been able to give it up. But it basically means that, like a person can maybe still live alone, so you don't need to act their personal directive, but maybe they can't manage their finances and you need to enact their power of attorney. And similarly, they may not be able to manage their money or choose where to live, but they may still be able to, have that ability to pick a decision maker. And that's really important because that'll save you time from going through the whole like office of the public guardian and applying for one formally. I often like a colleague of mine likes to think of it as domains, and it's sort of like the ability to pick a decision maker just takes less skill than it does like to have insight on like say driving a car or taking your medications or even who to associate with. So I like to think of like personal matters itself as a big domain and have all these like very specific, task specific things that you can do. And the same goes for money. Like they have actually identified 8 different levels of specific skills within managing money, where like the basic managing of just like tendering money when you're paying, like taking money out of your wallet is the simplest. Financial assessments are probably at you know, the most complicated, and past financial exploitation also fits in there. So let's talk about another case. Mrs. Generous, she was admitted with a UTI, and there's this query like elder abuse. The daughter had brought it up. She's an accountant by trade, and she's named as the agent attorney. And when you call her, she says, no, I think my mom is doing pretty well at home, except she has donated a large number of times, like more than 10 times in smaller sums of money to this really big church. The church would call her and just ask for donations, and she would donate. And in a year, she donated over $80,000. And as you know, then the church was like, this is awesome. We'll keep calling the patient for another donation. And then that affected her ability to qualify for Social Security and old age pension because she was over that magic number. And when the daughter called the church, they were like, no, we didn't do anything wrong. But the daughter feels otherwise. Her mom is able to stay at home and she is quite safe. So, what would you do? Would you enact the PD and the power of attorney? Would you enact just the PD? Just remember the PD is for personal things, the power of attorney is just for money, or put limits on her bank card withdrawals. Oh, good. Yes. So, yeah, so we wouldn't do both the PD because that's personal things, right? And she's safe to be at home. And so you wouldn't want to take her personal ability away because she still has that decision-making ability. Um, I wouldn't do both just for the reasons like the task specificity that we talked about. The problem really here is about money, right? So I agree, I would enact her PD. Now, when you put like you could put limits on her bank withdrawals, it's actually really hard, right? So I kind of put that in there as a trick question. Each bank is so different, and sometimes like children are co-signers, but it's getting harder and harder. And even banks are making their own power of attorneys that they want enacted, right? So the best way in here is to make the power of attorney, then you're in charge, and then you can go to the bank and say, this is the limit I allow my mom to do bank withdrawals on, right? You can still give them that freedom, but it's harder to do the other way around. And also, if the bank has their own power of attorney, you may be forced to enact it. But if you have that bank power of attorney, it's not the same. You can't then go to the government, like when you apply for, like, say, top ups or blah, 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 like social, like security or whatever. They will need the official government one or the one that's done through a lawyer done. The last pragmatic risk is just consider past and future risk, like what happened before, especially if they've been really sick. Like if there's something that lands them into the hospital and it's something acute that you fixed, but if they have a big history of, like we talked about, wandering, financial abuse, you'll get a lot of this at home. Like, sorry, not at home, but as an outpatient. I see this all the time where, they get like they succumb to the carpet salesman. And if it's like really substantial, and I'm telling you, like, it is so big out there and the patient lacks insight, like that they were phished or scammed, I will have no, I will, my threshold is low these days because, like for most elderly retired people, like losing 30, $40,000 in savings is a big ta-da, right? And sometimes my colleagues will go, well, but like we don't want to get involved. And you have to get involved, right? Like their savings are really part of what's going to keep them afloat for the future. And this researcher, Lichtenberg, he made this financial decision-making scale. And you can see that, like he says, he actually also, agrees that past financial exploitation would be something you consider when you go into these are just another way of saying the four core skills of assessing capacity. And then you come up with a decision. So this is a case I had very recently, the brain and the brawn. You often get this in couples that like live together at home. Like one has more physical function, one has more brain function. But these guys both had like dementia. They were both admitted to the hospital. The husband was more frail from underlying lymphoma. And when he fell in the garden, his wife went inside and she forgot about him. So they were both somehow admitted independent because like like the EMS, they're very smart and kind. They recognized that she couldn't like do anything without him. Um, and they both needed 24-hour queuing. And then we had a family meeting. And the system case manager said that the husband had refused to let home care in the house, but the wife would probably be agreeable. And there's no PD power of attorney in place, but both patients agree that they would pick the son as their decision maker. And he lives in Edmonton and they trust him. Now we have this brand new Alberta Health Services mandate that patients have to be placed from home. And the systems case manager is came to this meeting and she said, if you enact the personal directive now, I can place them urgently and put them on the placement list. So instead of waiting like 6 months or whatever, they would probably be placed within weeks. So what would you do? Would you establish a PD power of attorney, enact the PD, and act the power of attorney, or all of the above? Okay, let's see what we got. Yes, I have done 79% yes, all of the above. So they don't have one. There is no PD. So we need to do that, right? That's bottom line. So A would be in there. And then we're going to enact the PD and the power of attorney because the power of attorney, we need the finances to get them placed. And this is a living in situation. They both don't want to be placed. So we're going to enact it. And it's kind of funny. Like sometimes when I'm in the hospital, the social worker will get mad at me and go, well, can't you just at least say because I'm basically saying they have capacity to pick a decision maker, but they don't have capacity to live at home and and manage their finances. And it kind of is always quite upsetting for the social worker. But I always say, hey, those are different tasks. I can do them all at the same time. Oops, and then we go to the next one. So really quickly, four types of scenario. Quite often, capacity is so confusing because you'll just say assess capacity. But really what you need to do is like to identify like what is the trigger and what is it for. And the longer I do this, it can almost always follow in one of these four. For medical treatments, which I hardly ever get, choosing a decision maker, which is what you would do if they don't have it in place, like a PD and the power of attorney. Is it personal or choosing where to live, or is it managing finances? So you need to like figure out what are they actually wanting the capacity for, right? And I'm going to give you some questions, but I really say make it your own assessment. My only advice is be very direct and do it a little bit sugar coated. The direct, I have this picture when I was a medical student, I did this like elective in Quito, Ecuador, and they have this like crazy airport, which is like, this strip, this 10-kilometer strip, or maybe shorter, but it's like 360 surround sound mountains. And so basically you got to land the airplane. And I always think Like when you do this assessment, you want to be really sweet and not be threatening. You can't say, like, go in there and go, I'm here to assess your capacity. And if you fail, you're going to long-term care. Because even the patient with the most profound dementia will, like, they will not engage in conversation. You want to be really non-threatening. And I always say, hey, do you mind if I ask some decision-making ability questions? I just want to see how it's going. And then they'll be like, oh, yeah, go ahead. And you got to not putz around too long because they don't have a lot of concentration and they get very confused. You got to get to the point. Okay. So for medical treatments, it's things like, it's very straightforward to help me understand what's happening. What are the treatments available to you? What may happen? What could happen if you didn't have therapy? And then, tell me why you're choosing this treatment. Change the topic and then ask them to repeat it, right? So, in theory, we should be doing this for all medical treatments. But I remember in medical school, we never hardly ever did this. We did it like we would just read the risks, right? Like, and you're going to have a 10% risk of emboli if you do this, blah, blah, blah. So we should really do it for everything. But especially we should do it if we have risky procedures that have potentially life-altering situations or very low-risk procedures that patients don't want, but they have very favorable outcomes. This one paper I read, and it was very good. Like sometimes a patient wants something, and it's really not like it's not an option. So, what you can do is you can give them preferences. You can literally say, hey, if you had to have a choice between A and B, which one would be more favorable to you? And that way, you're still kind of including them in preferences. Choosing a decision maker, I usually just say, as we get older, it's a good idea to pick someone. Like, say, if we weren't alive, who do you trust the most? If you were in a coma, who would you want to make decisions for you? Because that's something that's not threatening. It doesn't really relate to the dementia. And then after several minutes, I'll change the topic and I'll come back to it and ask them again, can you tell me again who you trust most in this world? Choosing with where to live is probably the hardest one. I usually start out with, and I say, tell me about some of your medical conditions. Do you know what brought you into the hospital? How are things going now? Do you think you'd be able to go home safely? What do you need to be able to go home safely, right? Now, quite often, if they're kind of like, if it's right on the fence and they really don't have insight, but their function is so good, right? They don't qualify for anything. I'll often ask like for that cognitive. Now, the MOCA is not going to tell you, but what's a really good test is the independent, we call it the safety ILS. And again, if you're practicing in the clinic, you may not have access to this. But if you're like practicing in the hospital, you would ask your OT, and they'll kind of tell you that this patient, or, again, and you get that functional assessment, and they'll comment like, I really think they are not safe to live at home by themselves. Finances are quite a bit, again, it's more straightforward. Um, so it's very like factual, declarative facts. But as we talked before, there's many layers. So my typical questions are, tell me where you live, how much is your house worth, how much is your rent, how much is your property tax? Tell me about your assets. Do you know how much income you have every month? What are some of the bills that you have to pay every month? And then if you have that history of a financial exploitation, you're going to explore that, right? You're going to go, what happened? Did you have any bad things? Like, do you remember this incident? What do you think happened, right? And now we're going to move on to the kind of the more factual. So what happens, you're going to like choose the Alberta, you're going to Google Alberta capacity, and I put in schedule 2 or 3. But I want you to know there's a schedule 2 or 3. And if you can't remember it, one of my nurses gave me this rule a couple of years ago is you're going to look at the power, the personal directive, and you're going to look at it, and as well as the power of attorney. And if it says this is going to be enacted by one physician, then you think that's the N+1 rule, right? This is not about shoes or purses or bikes or skis. This is the N+1 rule when it comes to what it says on the personal directive or power of attorney. So if it's one decision maker N+1, that'll be a Schedule 2. But if it's two physicians, so N like 2+1, that'll be a Schedule 3. And this is, I put in my 99% of the time, it's going to be a physician and the agent, so like the family member. So you can see this is my PD. I had my will made a couple of years back, and they threw in a PD in power. And the modern wills, which I really like, I say modern because I hope everyone is doing this. It says my agent, blah blah. When my agent and the physician, or if my agent is unwilling, then we go to two physicians. So it's kind of like a backup, right? Um, and this is again like those four things, like the four skills: understand, retain, identify, appreciate, blah, blah, blah. And this is just to say you don't have to write a thesis when you're doing it. You can just say, like, the patient lacks and appreciates. We need this for doing this for a higher level of care. They can't remember anything, even when explained. Like sometimes the question I often get, does everyone have to be a yes? No, it doesn't. But I like to make it yes because I think it's just easier on the Office of the Public Guardian, and then they don't have to be like, ooh, what's going on here? And so, for example, if a patient like consistently says, I want to go home, I want to go home, I can just say patient consistently unable to recognize limitations. And then at the very end, it says, I attached a more decent, I don't do this. I will leave a note, though. It's important to document in a progress note, like what actually went down in the conversation. And you have this little box that says, should they be reviewed? Now, I had a lady once, she had such severe hypothyroidism, like her TSH was over 100. And so I was curious myself, like, is she going to get better? And I did follow her for years. She did get better, but she was never really normal after that, you know. And I think she probably had a little bit of underlying dementia to begin with. And the other one, in theory, is Wernicke-Korsakoff. But even then, I don't know, you know, if you have a long history of alcohol abuse disorder, like, do you ever improve back to baseline? In theory, yes, never say never, but I'm not so sure. So I usually say no, but you know, you could potentially say yes. And this is a power of attorney enactment. Like this would be a two physician, and it's simple, right? Like you would just document your name, the person's name, sign off on it. But I encourage you to just leave a quick note in your charting, right? Because you never want those things to bite you in the butt. Now, if you're a Connect Care user, I highly recommend, if you look on like we love it, and it's really good for like other people, like the home care workers, to have this. So you would just go, and you see here, there's nothing on the left-hand side, but you would click on Navigator, you get into capacity status, then you go incapacitated. And when it comes back up after like their goals of care, it now says alternative decision maker is active. And that just makes it easier for everyone. Oops. And so if we put it all together, you know, I put this is how my brain kind of like, in fact, I think because I've been doing it for so long, all the inputs happen and I think about my 444. But if you get a thing for capacity assessment, is there a trigger, right? Make sure they're not delirious, that they're medically optimized. And then identify what domain are they actually, like, is it personal, financial? And then ask yourself, is there a trigger? And if there isn't a trigger, a true trigger, then you know you don't need to assess. Now, if the capacity is for disposition planning, then make sure a functional is assessment is done. And then also ask, is there a legal alternate decision maker? And if there isn't, you can actually assess the capacity just to get that ball rolling. If they don't lack capacity to pick an alternate decision maker, you're going to have to put in a formal application to the Office of the Public Guardian, which then, like, you either, you know, family applies or a public one, and that gets forwarded to the courts eventually for them to sign off on it. But if there is a legal decision maker, or you were able to establish one, and you're again using that UR skills, then you can actually go to assess capacity using that understand, assess, reason, and express. And finally, while you're doing that, please always assess the past risks, future risks, like what will happen when I enact this. And that's kind of what we have. And yeah, I'm done.
Thanks so much, Diana. There's definitely a few questions here, and just a reminder for everyone that questions should be posted in the Q&A and not in the chat box, please. But we've got a few ready to go already. Um, Diana, this is the one that has most votes actually, is that some long-term care facilities require that the personal directive be activated in order to admit the patient. Is that a good enough trigger?
Yes and no. I had this happen to me. I used to work out in Stony Plain, and there was this new facility, Copper Sky, and they needed it. And it made me so mad because there wasn't really a trigger. They were just applying to be on there. So I will sometimes try to reason with them and say, no, you don't need this. Like, what is, especially if the person is in agreement, you can just say, no, I don't see that trigger here. The patient is in agreement to go to long-term care. But if they absolutely require it, yes, I will sometimes do it. Just it's like your arm is being twisted, and you can state it and say, they're in agreement to go, but it's a requirement. Yes. What
Yeah.
do you think, Karen?
Yeah, I mean, I have a lot of experience in this as well, and I actually do go back and talk to the facility because they cannot mandate that somebody's personal directive is enacted in order to admit them.
Yeah.
It's actually, yeah, it's in some facilities, same thing. They tell you that you can't be admitted here if you don't have a personal directive, and that's really actually illegal in the law. There's actually a
Yeah.
$10,000 fine for forcing somebody to create a legal document they're
Yeah.
not willing to
And
do.
so I totally agree. So Karen's worked a little bit more in the outpatient. Yeah, so you're kind of being forced. And I think like I just try to understand. I think from their perspective, they just want to have a backup. They don't want to be stuck trying to find someone to enact it, but it's really not appropriate, and it's actually really inappropriate. So, like talking to them and educating them. Believe it or not, I get it all the times in the hospital too, with social workers, and they go, but they have dementia and they don't understand they're going. And I'm like, yeah, but I like when I get my car fixed, I don't actually understand like what is going on, but I know enough to say I don't need to go home or I don't not want my car fixed in this situation. So you just have to kind of explain it to them. But yeah, great question.
So then the next question is Schedule 2 requires consent from the patient to start the capacity assessment. What happens when the patient does not consent to the capacity assessment? Can we continue with the assessment? What if the patient lacks capacity to understand the purpose of the capacity assessment? Then how do they give consent?
Yeah, so this is a good one. And again, I'll get Karen to chime in. I forget what form it is. Some of the older ones, like you're supposed to say, oh, do you agree to capacity assessments? And it's like, I think the Form 6, especially because they're so old and outdated, will always say, have you talked to the patient? Do they understand? And it's like, oh my gosh, like, so that's why I say like sugarcoat it, and just use that non-threatening language. But no, if a person doesn't want to agree, like it's tough luck. Like, what are you going to do, right? You got to stop right then and there because then they get really defensive and paranoid. And then it just has to go to the Office of the Public Guardian. So my recommendation is non-threatening language. Um, like I do agree that you have to let them know, but you don't have to say, I'm doing a capacity. Like that's just me. It's a little bit sugar-coated. Karen, what do you say?
Yeah, I'm usually very honest with them. I start off like, do you know, why I'm here? And I tell them like, people are concerned about you and the worried you're not able to make your decisions. And I'm really here to talk to you about what your perspective is and understand where you're coming from.
Yeah,
And I
so
would love,
non-threatening, but you're
yeah.
not like saying capacity and you're going to long-term care because you will get a zippered lips right away. Like that is so I like what you're saying too. Yeah, like we're just worried about you. Let's have a conversation. Yeah.
Yeah, and it's like really giving them a chance to speak for themselves because some patients they'll decline, and that's okay. And I just tell them that I will still go forward with my assessment, but it just means that you don't have your say because I have to base my opinion then on what everybody else says and not what you say.
Yeah, and that's a thank you, Karen. I love that actually. I'll incorporate that into my another question. I love my colleagues. We learn so much from each other. But yeah, the assessment goes, right? Keep
Mhm.
going. Yep.
So the next question is, if someone has been reliant on others for IADLs, how do you determine if there's been a change of function?
Well, if they rely on someone for IADLs, that's a really tough one. Often, what I do is, you have to be really blunt with the family and say, if you weren't there, could they manage the finances by themselves? Like, what if you weren't doing it? And yeah, it's really interesting because like sometimes I don't want to use bad language, but I always like to say it's like a kept woman or a kept man, right? Like, or it's just the way the family dynamics have functioned. Like maybe they don't do finances because it's like highly computerized and a lot of our elderly don't feel comfortable doing that. But you really have to say, like, kind of say, if they did it, could they do it on their own? And have you noticed, like, if they've always done it, or like if they've never always done it, then it's really hard to assess function. But if it's all of their IEDLs, like that's really suspect, Karen.
Yeah, I agree. But yeah, like we all know those like really elderly men who have never made a meal or washed their laundry or anything else. And the question is, could they maybe do it? Hard to
Yeah.
say, but it is
But if
difficult.
you
And
if you say that, because I get that, like for me, finances is by far numero uno, most sensitive, highest function thing. And so, like, if you really bear down and say, yeah, but if you weren't there, would they remember to pay bills? And then family goes, actually, no, right?
yeah,
So, yeah.
no, that makes sense. So somebody wants you to confirm, so you can establish a PD and EPOA when they don't have capacity to make other decisions. It's because the level of cognitive difficulty for both is different. Can they just want you to
Yeah, like it's
confirm?
just the way I explain it, I had a talk with, so it's in my paper too. Like, it's just not as difficult as maybe deciding on where to live, manage finances. And part of that, like, if you think about how dementia is, it's emotional, who we trust, right? So it's almost its own little storage capacity, but also it's been there for a long time. And if you think about it, like your relationship with someone, it's been around for so long that it's almost automatic. Do you know what I mean? Like, and that's the part of dementia, like the long ago memory. People always go, oh, yeah, but they remember, their memory is so good. They remember things from 30 years ago, but they can't remember a recent conversation. But that is how Alzheimer's dementia and a lot of dementias work, is that it's the recent memory they can't remember, right? So that long ago memory, and also because it's emotional, and so I literally like I'll have couples where the wife is trying to commit the husband to long-term care and he's so mad and he knows it. But if I say to him like, "Hey, who do you trust most in this world to make decisions for you?" He goes, "Well, her, of course." Right? So, and I'll give you a little tip. The reason I do this now, if I think there is financial abuse or like something's fishy's going on, I don't want to be involved. I send that one off to the office of the public guardian, and you should too. But if that caretaker is very reliable and caring and you believe them, you are doing our healthcare system a great big favor, because chances are when it goes to the office of the public guardian, we don't have enough money or resources to assign public guardians. They want family to do it. And in Ontario, actually, is very systematic. Like they'll go, it's called a hierarchy of succession. They'll go husband, oldest kid, next oldest kid, next oldest kid. So if you find someone that you think is really reliable and is good and wants to do it, even if that's a friend, you're just saving the healthcare system and that patient so much time, because it takes months and months and months. What do you think, Karen?
Yeah, I mean, it depends. And like, I'm gonna go to this next question, which actually kind of is related. Somebody's asking, what are the options when the patient is thinking of naming someone who you think is not suitable? Like they may be exploiting them, or where the decision may be being coerced. Um, and that's kind of like the same sort of thing you're just talking about right now,
Yeah,
Diana.
when it's like that, you gotta be honest and and I just bring it like hands off and I bring it forward to the office of the public guardian. Okay, I take it back. I had one where I actually very much trusted the family member that was telling me about how this other family member was exploiting them. And then there wasn't a PD enacted, so we made a PD that was made the reliable family member. And it can be tricky. And if you don't feel comfortable, don't do it. But I have quite often, I go really into like interviewing people. I kind of, I'll be quite honest. I had like this fascinating case. He was like a millionaire and it was so much money on the line. And I like interviewed, like it was a very complex situation where a friend who used to be his business lawyer, and then he had like children that lived in Germany. Like I just interviewed so many people. And at the end of the day, like I really made my decision. And I liked how the lawyer actually wanted the child like it just was it seemed right and it felt right and I knew that's how the court and I documented everything and I even like talked to CMPA and they supported what I did. But if you're really unsure, then just document and go to the office of the public guardian. Yeah.
Yeah, like, and yeah, that's my answer. I would, my thought to it. I'd always leave it for guardianship trusteeship, and then whoever wants to be the decision makers can basically apply to court for it,
Yeah.
and like court can determine. But yeah, definitely, I would document if there's any question about,
But
expectations of
I
court.
just want to say like sometimes if you have really good, like you feel very confident, then I think you like as long as it says, say if it's like five people agree and the one family member is the bad apple, anyways, any more questions? Yeah.
Yeah, yeah, there is.
And guys,
So
I just want
is
to
it?
say this is the hardest of the hard stuff. So don't beat yourself. Like this is the stuff it took me years and I used to beat myself up. You can't do it in one day, is what I say. Like sometimes you need to talk to colleagues, call geriatrics on call, like run it by them. These are the hardest of the hard things. Yeah.
Yeah. Is it legal for an MD to remove a patient's capacity for personal and financial decisions without talking with a family member? This happened to a family member in Ontario.
Say, is it,
So is it legal for an MD to remove capacity for personal and financial decisions without talking to a family member?
it's really bad form, to be quite honest, because like if the patient lacks capacity, who are you getting your information from? Do you know what I mean? Like you
Yeah,
need
but
to
it
get,
depends, right? Like who's
yeah,
named. If there's documents, who's named, because they only have to contact the person who's named on the document, and they
yeah,
don't have to call, all seven children.
no.
Like,
No, but yeah, so I would definitely, and again, like what was the trigger? Were they going to be placed, right? Maybe family wants to take that, like, culturally, families are so different. There is some culturally families where you can take someone that, like, multi-generations live in that family and they manage that patient. It's just part of their culture. Then why would you take their autonomy away? I always say you want to do the least harm, right? But I also want to be an advocate. Like if I know like power of attorney, again, I want to talk to family and say, what's the situation? Who's managing? Oh, you're like, yeah. So I just think it's bad form. And these are the kind of things like, um, and actually, it happened. Like this happened while I was working. And these are the things you could get written up to the Royal College because you haven't, like a family member could complain. You really should talk to family members. It's just the right thing to do, right?
if you can, yeah,
If you can.
yeah, if you can, but definitely, especially sometimes out of town. Bad form, but not illegal. Yeah, definitely not. It's not illegal at all. As long as they've met the criteria of their doing their capacity assessment and enacting the documents or declaring them incapable and putting it to the courts basically for
Yeah.
guardianship and trusteeship, it's totally
Yeah.
legal.
Just it's legal, but you're gonna like if people complain, you may have to defend yourself to your local, the Royal College of Alberta and CMPA. So you have to document again, what was your trigger? What was going to be, yeah. Is there any
Mhm.
other questions, Karen?
Just a real quick one here. Unfortunately, will be the last one. If a patient is unable to make financial decisions but still able to manage at home, should capacity assessment be done only for power of attorney at first, then another capacity assessment done in the future for PD?
Correct. That's exactly what I meant about task specificity, right? You want to do the least harm and power of attorney. It's quite often, it just makes sense. And you know what? Like I had a capacity assessment the other day and the lady is actually quite with it, but her son's been doing it, and it's very functionally related. Like she can't, like physically, she can't get to the bank anymore. And so I just told her, I just said, you know what, like, I know it's working for you right now, but we're gonna like we have to apply for extra, like your son's gonna have to sell the house and blah blah blah, and it just gets too hard. I'm going to make this like more like sometimes you can tell them, do you mind if we make it more formal? And they'll agree. But yes, if that's a takeaway message from my talk, you don't need to take capacity all the way at once. In fact, I urge you to just always do whatever you need to do. I'll give you one situation on the personal one that I've had. Like a couple of it's happened where people, because there's like little tick boxes on the personal, and people will say, um, I don't think this person has capacity with whom they should interact. And that's a funny one, right? Again, if you don't have, like, if you're going to send them out in the community, but you don't want their drunk friends to interact with them, that doesn't work. Okay. Like, again, I go back, you have to have a place to actually keep them away from this bad actor. So that's something that's very task specific. And you walk it through, you think it through, is that going to work? But most of the time, the two domains, personal, uh, and I actually have a quick one. I'm gonna just Karen. I almost never enact a personal directive for medical things. I just document and
Huh.
chart. How about you?
I'm almost always enacted for medical things because that's the
Like
reason why.
medical therapies? Yeah, like kind
Yeah.
of. But
But
if
it's
it's
for
like,
all medical decisions, right? Like if they don't
yeah,
know,
but if
they
it's
don't
just
know.
like for a one-time surgery or something, yeah, it's kind of interesting. I guess, yes, maybe for medical decisions. Anyways, I often just document it, but I don't take their complete autonomy away. But it's interesting.
Yeah. No, I almost always tick that box actually.
But then it becomes hard, right? Because then like that
Mm.
personal directive may be, yeah, anyways, you guys can see how tricky it gets, right?
Mhm. Yeah. Thank you so much, everyone. Our time is out. We even stayed past a little bit. We had one question we couldn't answer that was in the chat box, but that's all the time we have. This webinar, along with the other ones in the series, will be posted or have been posted already to the Lifelong Learning website. Thanks so much for attending today, and thank you so much, Diana.
Thanks, Karen, for joining in on the answers. I loved having you there. Thanks. Bye.
Thank you so much, Diana.